No matter where your agency is today in the process of taking your campus tobacco-free, whether you're just starting to stand on the left side of this cliff and look over to decide, when and how you're going to make this change, if you're discussing it internally, writing policies, working on staff training and readiness, putting up signs, or if you've taken the leap to go live. Either way, we really believe that this is a change worth making, and it can make a huge difference in the health and wellness of all of our members and all of us, especially those working toward recovery. I would like to introduce your partners team today for the next couple of hours. I'm Amy McGarity. I'm with Population Health and I'm Programs and Initiatives Manager. So hello. And we also have Delton Russell waving at you. Hey, Delton. He is our Population Health Recovery Specialist. He's got lots of experience working with folks in recovery and also has lived experience himself. And then we have Ted Thomas, who is our Training and Development Manager. Welcome. And last but not least, we have Mandy Mayhew, who's our Integration and Development Assistant, but also for today, she is our Production Manager for this event. And trust me, there's a lot of moving pieces. So kudos to Mandy. All right. We definitely have a packed agenda today. This is what we're looking to accomplish. We're going to move through it pretty quickly because we only have 2 hours. Our goal is to bring you a sampling of these great topics, covering all the different aspects about moving through the process of going tobacco-free. We want to give you a taste for these areas. We know that you're going to have more questions. We just want you to see where you need more information, and then by the time you leave, hopefully you will know where to go to get that information and extra training. And if you will, we've got a pretty big crowd, so we're going to hold the questions till the end, and we'll be glad if we need to stay over just a little bit. We'll try to address whatever questions we can, and we'll have contact information as well. So before we get started on that agenda, we want to take a moment to give you a 10,000-foot view of Partners Living Tobacco-Free Wellness Program. As a tailored plan, we're moving forward with initiatives like this to improve the integration of physical and behavioral health. Living Tobacco-Free is a comprehensive community wellness program to help our members and recipients to live tobacco-free lives and improve overall health. I want to take a moment here to mention that if any of you will be working with American Indians and Alaska Natives, I want to point out that traditional tobacco is different from commercial tobacco use. Lots of tribes use traditional tobacco for ceremonial purposes such as funerals, weddings, harvest time, etc. And it's used for not for pleasure. It's not inhaled like a cigarette, but it's used respectfully with honor. If you want to learn more about that, you can go to Breathe Easy NC. They have a good section about it, but also Partners has a tribal liaison staff named Shelby Holland. And she, I put her contact information at the end. She will be happy to talk to you about any questions or specifics if you're interested. Our program is really, we have lots of interventions. We're going to use education, prevention, safe settings, as we're here today to talk about, tobacco screenings, and treatment, along with access to gum patches and lozenges, and supportive coaching. And that is through our Quit for Life and Quitline NC programs. We're going to touch members. We're going to work with providers like yourselves, both primary health care and physical health providers, as well as our behavioral health providers. And also, we're going to be working in the community to create awareness and link resources together so that, you know, we can all make an impact at all these different levels. The why, we're going to talk about that a lot more today, but generally speaking, we all know that tobacco use does contribute to a number of chronic conditions. And even though we've made a lot of progress, tobacco use still remains the leading preventable cause of death and disease in the US and North Carolina. So tobacco cessation can save lives and improve overall health. But there's more to the story. And I'm going to, Delton Russell is going to take a moment to talk about how quitting can impact the recovery process. So Delton, take it away.
Hey, everybody. So, you know, I know when I first got sober, you know, I would hear people say, when I talked about quitting smoking at the same time, I'd hear people say, you know, just do one thing at a time. Don't do too much at once. And I'm really grateful that I didn't take that advice. I saw nicotine. All right, sorry, got it muted. But anyways, when I first got sober, I saw nicotine as a drug, and I saw that I was definitely using it in ways that was not helpful to me. So, long story short, if we look at how nicotine impacts one's recovery, we can see that you know, due to its high levels of dopamine releases, it causes barriers to neuroplasticity being created. So, you know, from a data standpoint, we know that if a person quits using nicotine at the same time that they initially get sober, they increase the sustainability of their recovery by up to 25%. And for those of you who look at data in relationship to sobriety, 25% is a huge increase. So yeah, so you know, if we stop using nicotine whenever we first get sober, it creates a high likelihood of creating opportunities for neuroplasticity. And then on top of that, you know, we also want to talk about, you know, we talk a lot about health outcomes, and it's not just the person receiving the services, the person that's in recovery. It's not just their health outcomes. It's also the health outcomes of the providers that work with them, primarily for two reasons. One, you know, that provider isn't subjected to secondhand smoke with the frequency that maybe they were before. And also, you know, with the tobacco-free campus, we don't have people smoking on campus. And as a byproduct of that, you know, it creates greater incentive for them to quit themselves. So people that work, you know, clinicians, peer supports, whoever, you know, they're more likely to stop smoking as well.
Thank you, Delton. So I'm not going to go into detail here, I just wanted you to see the main goals of our Living Tobacco Free program. It includes prevention and wellness, recovery management, safe settings, and working with members with chronic conditions so that we can help them strategize on quitting tobacco use and connecting them with the tools to do that. So really, I just want you to remember we're trying to brand our program, and it is Partners Living Tobacco Free. So when you hear that, you'll know that's our program. So in wrapping this overview up, we're partnering with our providers. That's what we're doing today, to talk about resources and training. We're rolling out a little mini web page on our provider knowledge base. And if we have time today, I can demo that for you. It should be ready in the next week or so, but it will keep you in the know for resources, events, trainings, and all sorts of resources for you. So we're excited about that. And just so you know, it'll be, if you go to provider knowledge base and then you go down to the little file icon, tailored plan, and then tobacco resources, that's where it's going to be located. So not only that, we as a staff, our care management team and our member engagement staff, we're going to be reaching out and engaging with our members also to help educate them, do some screening, and referring to your treatment programs. We're going to be also linking them to Quit for Life and Quitline, so that they can have coaching services and access to free nicotine replacement therapy. It is their chances for recovering are double when you combine counseling with nicotine replacement therapy. So we want to really emphasize that and connect as many people as we can throughout this program. Also, and last, we're going to be outreaching to our community, as I said before, to create awareness and connect some of those dots so that we're all on the same page with this. And it's definitely a together thing, and you guys are a huge part of that partnership. So again, thank you for taking time out today to join us. And it's now time to introduce our panel of guest speakers. I'm really excited that we have them here. These are our field experts from Public Health's Tobacco Control Network. A lot of you probably know them and recognize their names. They have been road warriors for a long time, carrying this message, and of late, more virtual road warriors. But I'm going to hand it over to Ted Thomas to introduce our speakers. So thanks a lot. Here you go, Ted.
Thank you, Amy. And so glad to see so many of you here. So as you look at the page here, I'm just going to start to say welcome to Joyce Swetlick. She is with North Carolina Department of Health and Human Services, the Tobacco Prevention and Control Branch. So she'll be sharing with us. Stephanie Gans is also a Tobacco Prevention and Control Branch at DHHS. Yes, indeed. Welcome to the both of you. David Willard is currently Region 3 Tobacco Control Manager, and then Kim Baya is the Tobacco Prevention and Control Supervisor with Mecklenburg County Public Health. So these are our panelists today, and I believe first up, we're going to bring on Kim Baya, again, Tobacco Prevention and Control with Mecklenburg County. Take it away, Kim, all yours.
Thank you, Ted. Let me share my screen. and get going here. Okay. Can somebody give me a thumbs up? Amy, you see my screen? Okay. All right. I wanted to kick off the conversation today by first talking about why addressing tobacco use in the behavioral health population is so important. And both Amy and Delton touched on this, but it's worth repeating. And also I'm going to go a little bit deeper. And I think that the key to success is really knowing the why, communicating the why, and making sure everyone in your agency understands the why. So let's look at a little bit of data. We know that adult smoking rates in the general population in our country, in our state, in our communities is around 14% and actually declining. It's lower in some areas, but in the aggregate about 14%. But if you look at the behavioral health population, those rates of smoking and tobacco use can range from 32% to 98%. In fact, it's some of the highest of all of our subpopulations, and that those rates can vary by diagnoses. This is a chart that's interesting that shows various behavioral health diagnoses and what some of these smoking rates are. And you can see they're really just off the charts. And so addressing this in the behavioral health population is critical. When we look at subpopulations of tobacco use in our community, and this is national data from 2020, we know that there's some populations that are experiencing tobacco disparities, individuals with lower income, lower education, who lack access to health insurance, the LGBTQ community, active duty military, those who are in rural areas, and then look at behavioral health. You can see that the behavioral health rates of tobacco use are the highest of all the disparity groups. And so it really is imperative that we all partner, public health, health systems, behavioral health providers, to really look at, using those evidence-based strategies to bring these rates down. We know that as Amy mentioned, tobacco use remains the leading preventable cause of death in our communities. And in fact, about 480,000 people in the US alone die annually from tobacco use. And when you look at individuals with behavioral health conditions, make up almost half of that number. And so it really is a huge disparity within the behavioral health population. And we know that 50% of those with behavioral health conditions are dying, not because of their behavioral health condition, but because of chronic disease from tobacco use. And so it really is a wake-up call that we need to do something. This is data that shows in North Carolina. I know there's a lot going on the screen here, but let me just point out in North Carolina, the tobacco use rates. If you look at the bottom blue line, it shows about 17% of adults using tobacco in the general population. If you look at this middle purple line, 57% of individuals with some type of mental health condition. And then this top green line shows 64% of those experiencing substance use disorder are also using tobacco. So these are really high rates. And you have to ask why. Why are these rates so high? Why does this disparity exist? And we know that there is a long history of the tobacco industry targeting the behavioral health community. And that ranges from giving away free cigarettes to behavioral health facilities, lobbying against smoke-free, tobacco-free policies. And funding research that perpetuates the myth that this population needs tobacco to calm down, to self-regulate, to deal with stress. And that narrative that they have promoted has really taken hold in the lay community, in the professional community. And so, it's time to turn the curve on that and really to look at, are we providing services and environments to help individuals tackle their tobacco use addiction instead of stacking the odds against them. We also know that in the behavioral health population that there is a strong connection between early childhood adversity and substance use. You guys all know that, but that includes tobacco use. And so this population has a lot of things against them in terms of the likelihood of using tobacco. But here's the great news, and that is that there really is no difference between the general population and the desire to quit and the behavioral health population. It is a myth that those in the behavioral health population can't quit and don't want to quit. And this is data that shows, you can see the top line is the general population. The purple is they intend to quit in the next 6 months. The green intend to quit in the next 30 days. And you can see the general population on the top, and then all of these others are various, psychiatric outpatients, inpatients, MAT programs. They in fact do want to quit at the same, if not higher rates than the general population. So we have heard, when you hear some pushback, sometimes you hear, well, how is this being patient-centered, person-centered, if we're requiring folks to be tobacco-free in our facilities? But if you look at the fact that a high number, 3/4 of those with behavioral health conditions want to quit and can quit, although they may need a little bit longer tobacco treatment, which Steph's going to talk about in a little bit. We know that change is always possible, and the extent to which people's lives can change is often beyond what we can imagine. So being patient-centered, person-centered is offering those tools to beat that addiction and providing that supportive environment. I wanted to repeat what Delton had mentioned about the connection between tobacco use, quitting tobacco use, and SUD recovery. One way to think about it, we don't wait for a patient to get their substance use under control before treating for HIV, diabetes, bipolar disorder. These are chronic conditions. And so tobacco use, tobacco addiction is a chronic condition. So why wait? We know that when you tackle those addictions at the same time, that there is a tremendous connection to successful recovery. We also know that 50% of those in treatment today will die, not because of drug use, but because of the tobacco-related illness. And this is just a very powerful statistic. We have, this is from data from Prochaska, who's done a lot of tobacco research, that addressing tobacco dependence during treatment for other substances is associated with a 25% increase in long-term abstinence from alcohol and other substances. So something to make sure everybody in your organization knows. Quitting tobacco supports mental health. It does not interfere or cause a decline. It supports mental health. When you quit, anxiety and depression and stress levels can lower, quality of life and positive mood improve. You can even decrease dosage of some medications used because of the way tobacco was metabolizing in the body. Improved oxygen levels, better concentration, and so improved quality of life and years of life. In looking at our North Carolina mental health and SUD treatment facilities, looking at what's currently going on, we know that we're a little bit better at screening for tobacco use than we are in actually following through with some of the evidence-based treatment, which we're going to talk about today. And this shows you that there's a lot of improvement that can happen in actually providing that smoke-free or tobacco-free campus, and also providing access to that evidence-based treatment. So I wanted to, just a couple more slides, and I'm going to kick it off to Carlene. I wanted to go over the benefits of a tobacco-free campus policy. We know that those policies support staff and clients who want to quit, and actually providing that tobacco-free environment is an important component of tobacco use treatment. so that policy is a part of that treatment. Promoting a healthy, policies promote a healthy environment for all, including a cleaner environment and eliminating the exposure to secondhand smoke and e-cigarette aerosol. It can increase job satisfaction for staff and again, support mental health and substance use disorder recovery. So it's real important to promote the why within your organization, foster discussions on how becoming 100% tobacco free actually does align with your organization's mission, vision and values, the mission to help people become well, and linking that policy to evidence-based treatment and also framing that policy around health equity. Everybody deserves the right to the same protections, and that is having access to clean air and access to tobacco treatment. So I'll end with this quote from Selma. I didn't survive drugs and alcohol so I could die from cancer. I had to stop smoking. So those are just a few of the salient reasons to support this work. And so I'm going to stop sharing and kick it back to Ted or Carlene. Thank you.
Yeah. Hey, Kim, thank you so much. And I appreciate the information that you brought there. Pretty impactful. I'm not a statistician, and actually I get choked up when I say that word. So I'm glad that you tied in the statistics to everything about being tobacco free. So thank you very much. And next up, yes, we have Carlene Crawford. And it is perhaps real that I failed to introduce you earlier, Carlene. And if that is the case, I'm so sorry. You are here now, right? Thank you.
I'm here.
And I love this. Yeah, I love this first graphic. All right, it's up to
All
you.
right.
Take it away.
Thank you so much and great job, Kim. I'm going to talk to you a little bit today about our tobacco-free organization roadmap. And, you know, we developed this looking at many recommendations from national and state toolkits and from our local experience working with behavioral health organizations who have gone tobacco free. And we know that the process is a journey that takes a lot of twists and turns, and it may even include some roadblocks or pushback along the way. That's sort of to be expected. But what we've learned is that taking a comprehensive approach, evidence-based, with positive communications and involving your staff and your stakeholders along the road, it'll help you reach your destination with success. So before I move on into the roadmap, and my slide is not moving here, I apologize. All right, I want to be sure and distinguish the difference between smoking and a smoke-free policy versus tobacco and a tobacco-free policy. So smoking, of course, includes all of those combustible products, the lighted tobacco products like pipes and cigarettes and cigars and hookah. When you look at all tobacco products, that includes those combustible products, but also the non-combustible products that we're seeing now on the market. I mean, the ones that have been around, your dips and your chews, those have been around for a while, but now we're seeing a product like snus. We've seen your electronic cigarettes, all the parts and components that go with it, the e-liquids. You've seen the new disposable electronic cigarettes now that are made with synthetic nicotine, and now we're even seeing some gummies. So all of these are tobacco products, and just to remind you that there is really no safe tobacco product, and that they all contain the addictive chemical nicotine. So it's important to expand the public's mental model of tobacco beyond cigarettes so that we include these emerging products and the types of products that disproportionately are used by our priority populations. And also we want to think about reframing language. So the language we use is fundamental in creating environments conducive to a recovery process. And so instead of saying smoking, how about tobacco use? Instead of a smoker, an individual with tobacco use disorder. Quit date, let's use recovery start date. Instead of saying a habit, let's reference it what it is, a chronic brain disease. Instead of cessation, let's say tobacco use disorder treatment and recovery. And instead of a smoking ban, let's talk about a tobacco and vape-free policy or tobacco-free quality of care improvement initiative. So it's really important to think about that. So what does 100% tobacco-free mean? Well, that means a policy applies to all of the property under a program's control, whether they rent it or own it. And that means their buildings, their grounds, and their vehicles are tobacco-free. It includes the use of all of these tobacco products that you just saw: combustible, electronic, heated, smokeless, and even those synthetic nicotine products, or any product that's not approved by the FDA for cessation. There should be no designated areas for tobacco use indoors or outdoors, and programs should not purchase, accept as donations, or distribute any tobacco products. So now that I've reviewed those, we're going to take a look at the roadmap and look at it step by step. We'll go into some deeper dives later on with different people really digging into these areas on the roadmap. I will remind you that communications, you see that they are all along the way. So let's start with making the case and building support. It's really important. It starts with staff. Kim just shared a lot of the whys, but building that awareness among stakeholders about the why with your leadership, board members, referral sources, staff, clients is really important. You really want them to embrace that. You can conduct listening sessions or surveys or interviews with staff and clients individually, separately. And then looking at identifying your internal and your external champions, that's really important, that can help support that work. And a wellness committee is a great way to approach it, and include all levels of your staff, even include someone who uses tobacco. The next step is actually developing your policy. And I'm not going to go into a lot of detail on that, but there is an excellent policy samples on the Breathe Easy NC website. And so, you can certainly take a look at that. Amy mentioned that earlier. Staff training. Educate all of your staff. Does everyone know the why? Clinical staff really needs to be trained to deliver best practice tobacco treatment. And that's something that you're going to hear a little more about from Steph as we move forward, but really important to do that. And in terms of developing your adopting your tobacco-free policy, also think about how to communicate that policy. I'm going to mention some communications as we move, but again, you don't have to do this by yourself. There are great resources available to help you. Signage, posters, cards, whatever you need to communicate. You can have those on site. Updating your website's really important with materials that are consistent to reflect your policy change. And again, Amy mentioned understanding that difference between commercial tobacco products and traditional tobacco products. So show respect for those. In terms of the clinical processes, you can see again that this is a critical step on the roadmap. And it's really important to put these in place to really integrate tobacco treatment across that patient journey. I'm not going to dig into it a lot. You can see some of the things here with the 5As and quitline referral, your EHR. Steph and Joyce are going to do a deeper dive into this, and in particular that cessation billing. Steph will touch on that. Medication access. So stay tuned because you got a lot of good information that's coming. And one thing I'm going to go back over here to develop and adopt your policy again is to plan for evaluation outcomes all along the way. And you can see down at the bottom the Stephen Covey quote that says, begin with the end in mind. So think about that when you're thinking about how you want to evaluate your work. Trying to get it to move and I can't get it to move. Here we go. Okay. So Quit Line NC is another key element to our roadmap. So there's some excellent resources available at no charge to support the clients and patients that you serve. And so stay tuned for that, because Joyce is going to take a deeper dive into the services of the Quit Line NC in just a little while and all of the great things that they offer. And she'll talk to you about, how to register as a referral site and use some of the protocols that they have in place for behavioral health. So exciting about that. Messaging and communications, an important part of every step along the way. And I'm going to touch on that in just a moment. But first, I want to move on, looking at preparing the environment. So that's another important step that in today's session, David Willard is going to actually highlight some great ideas for you in preparing the environment so that you can have healthy socialization and spaces. But you can see here on this list that there are a number of things that you can do to improve that and get ready. And then lastly, of course, that evaluation piece. And so we'll talk about that a little bit more. All right, so in thinking about communication, we want to communicate early and often about the policy change, and really at every step of your journey. It's important to use positive and motivational messaging. And there is some shared messaging available, like you see here with the Change for Life tobacco-free recovery. So those will be available to you if you're interested in using some, but it's important to promote and discuss the why throughout the journey. And then, be proud to have clean air and confident in offering evidence-based treatment. So set this as the standard for how staff should communicate about the policy. As Brian Kuhn from Pavilion likes to say, be affirmative. Don't be apologetic. This is a great thing for everyone that's involved. So, communicate in advance, communicate early, communicate often, and be sure and offer accurate information about the effects of tobacco use on your mental health, your physical health, and benefits of becoming tobacco-free in all your programming. Communicating carefully communicates you care. The Change for Life tobacco-free recovery web page, it has many, many resources. You can find that at tobaccofree.mecnc.gov. And so take a minute and take a look at some of the resources that are available to you. Under the communication tools are some of those messaging pieces that can be helpful to you as you move forward. So in terms of evaluation, we suggest that you ask these questions that actually come from your results-based accountability. I'm not going to read all of these. This is a laundry list of metrics for you to consider, but you will get a copy of this presentation so you can review them. But these three questions that we feel like are very valuable from RBA or results-based accountability is, how much did we do? How well did we do it? And is anyone better off? So you can look at some of these metrics. So for me in closing, I want to highlight our North Carolina state health region map to support tobacco prevention and control. And we will share this map with you, but you can see here in the light green is our Health Region 4. Above it is Health Region 3, and that's David. And then you'll notice some of you may be located in Health Region 2, the blue, which is currently vacant. If you're located in Health Region 2, please reach out to either me or David if you need support around this effort. And with that, I would encourage you to take a look at the tobacco-free roadmap, embrace it. And with that, I will stop and allow the next person to speak. So thanks for having me.
Carlene, yeah, this is Ted again. Wonderful. And the image that I'm left with is that image of all the different tobacco related products. I feel like I've been out of touch and you just brought me back. So
There are many.
thank you
Thank
so
you.
much. Indeed. Yes.
And they keep expanding.
Goodness gracious. No doubt. No doubt. So listen, I mean, it would be wrong for us to bring you in here and not only give you a whole bunch of information, but to not share with you how it's being done. So I want to bring over into this conversation some providers who have led the way, who have made this happen. And so we got some testimonials. Got Dr. Corey Richardson, clinical director, Rebecca Collins, program director, Bradley Wallace. Let me see here, grants policy officer, executive director of Recovery Now, from Integrated Care of Greater Hickory Treatment Center. And so I believe you've got a message to provide to us. So I'm going to put you on the spot here. Yep, there we go. Got a few of the cameras on. Awesome. All right, take it away.
Well, thank you for having us today. And and I really do believe this is kind of the Carlene show. She has been absolutely instrumental in making it happen. We have 5 treatment centers, the ICGH treatment centers. And about, I guess, 2 years ago when it was brought to us, or 18 months ago, I thought, of all the things that we are struggling with, why are we talking about this during COVID? And why are we talking about this with the opioid epidemic and all the other challenges that we have when it comes to placing our people in our housing programs? And she did. She really she connected with me on best practices. It was something that we included with every CCA. We always gave out information about Quitline. We had rules around our telehealth services, and we offered specific training and supervision around counseling. But it was obviously a secondary issue, and I didn't feel that we needed to make everything tobacco free. And then she gently reminded me that Medicaid was going to require it. And so I said, well, okay, we're going to talk. And so she sat down with a very doable strategic plan. And that plan included a long preparatory period so that the messaging that went out to obviously our staff, clinical staff, and what they were going to be responsible for, administrative staff, as they're going to be probably some of the guardians of our properties and our vehicles and everything else, and to our patients as we started to message the importance prior to any of the real strict rules that we were going to have to adhere to. So it was a longer process, but the strategic plan was there. It was it was guided, and constant reminders from Carlene were extremely helpful during, everybody on this call is very busy. And so that was always very helpful. She was always bringing free NRT to our pharmacists. We have clinic-based pharmacies, and so that was an added bonus, is that people could get from our own pharmacist NRT rather than always going through the Quitline. The staff that was going to be provided for all staff and then clinical staff was very, very helpful. We started with some signage, some very appropriately placed signage that was beautiful. And that included inside the facilities, in the doors, and then even in the parking lots, so that the messaging started to pick up. And then of course in our lobbies and in clinic offices, there was the brochures and the handouts. And even for our predominantly telehealth program, when they would come for a specimen collection, they would be able to pick that up as well. And so it's kind of a roundabout approach. It covered all the different avenues, if you will, that really made this possible. The templates for policy, I think Bradley will talk about how policy guided a lot of what we do. And then of course, Rebecca, I'll hand it off to Rebecca now and talk about the real implementation, because it's going to be your team right there that do the real work on each individual treatment site. So Becca, you want to pick up from where I left off?
Hey, yes. Hey, everyone. So I have to really say Carlene was really, she saved the day with us. We utilized everything from the Change for Life tobacco-free community. Every pamphlet, every bit of knowledge she provided, like we just absorbed it. Because we really in the beginning thought this is kind of impossible. But what we seen was everyone was eager, because we didn't just put a hard stop. We gently guided people through this. We provided the support. We didn't just say, well, this is a state rule and this is how it is. We were just very supportive with staff, with patients, with family members that may come, and when we would say, we are transitioning into a tobacco-free area. And then they would say, why? And I would say, well, why not? Come, let's have a conversation. And so we started offering the NRT. We upped our game with our clinical staff. We started including nicotine in our UDS services so that we could really take it to the sessions, with our patients and help them set goals. We provided Beat the Pack tobacco cessation courses for the staff, who then take it to the, to the clients. So really just being supportive is what I've seen, being that beacon of support and really helping them through each change of this. We've had a lot of success, staff and with patients, as far as now that we are there, we implemented it early. We actually went, so the first stop was in July, and that's what we were prepared for, was that hard stop in July. So we started this at the first of the year with Miss Carlene. And so it's been a wonderful journey with her. And we thank you so much for that support, Carlene. So anyone that's going through this, just using that quit line, we've sat with patients and called the quit line with them just to kind of guide them through it, to let them see how simple it is. It's a very simple app to use. You can download an app on your phone. They give you a coach who calls you every day, checks in on you. They will help them get free patches. They can even get them discounts on other NRTs, like the nasal spray, which I thought was fascinating. And then also helping them understand that vapes and chews and all of that falls into this category. So this has been a very learning, a great educational experience for us as well, on the other side of this. And what we have seen is when we hit this thing while we're dealing with all other substances, we are seeing better success rates on people stopping tobacco and staying, abstinence from it. So, and with that, I do have Bradley in here with me. I apologize. We had some technical issues, so I'm just going to pass it on to Bradley.
Awesome. All right. Sorry about that, everybody. Yeah, I was having some computer issues in my office. I just came up to Rebecca so I could make sure I got on board with everything. I did want to just kind of go over with the actual policy that we wrote, and kind of I went to Dr. Richardson and Rebecca before we went to staff and everything with it. And one of the big things that I kind of wanted to look at as I was writing was looking at this intersection of not only policy, but like Rebecca said, and like we've heard already this morning, the implementation and how we approach these conversations with people. I really wanted, policy can feel very impersonal and kind of very strict and stringent and oppressive at times if it's not met with these really nice conversations around need and how it's going to be implemented. And, coming on board, a relatively recent hire before I started writing this policy, and I don't want to be the new guy that comes in and writes this new policy and just kind of slaps it on the table and says, we've got to do this. And so I did really lean into people like Dr. Richardson and Rebecca and some other staff of ours to have these conversations and look into, where these treatments go and how they go hand in hand with the other treatments that we provide. How do we include that in our UDS? How do we include that in, new packets for new participants and new clients that we're taking on, and being able to go through all of that. And one section, I won't read through the whole thing, but I really was happy with how we were able to kind of cover the treatment assistance portion of our tobacco-free policy. We wanted to share with people what options we had available, patches, lozenges, things like Chantix, encouraging people to look at the, call the quit line, that 1-800 number, registering via text message. There's still so many things in our community that, you can't contact via text message, and for someone to be able to just kind of shoot out a quick text message and get that information right there in their hand and not having to set aside time, whether they're working or anything else, to make a phone call, but they can go back and revisit that as soon as they're able to. A big one that we've seen recently, I'd say I've noticed it a lot, and especially in the last 3 weeks, I don't know what it was that stuck out to me, is having all of our staff ready to have those conversations with people, whether they come in for a group, group session, an individual session, being able to have those conversations around, you're already here for these other treatments, you're already, wanting to get these things taken care of. Why not go ahead and look at, treatment and looking at including tobacco cessation and recovery from tobacco use in this long-term recovery that you're working toward. That is all for me, I do believe.
Thank you, Bradley.
Yeah, absolutely.
What I found is that initially we thought there'd be a lot of pushback from our population. Nicotine use disorder, it can be pretty common with those struggling with opiate use disorder, as well as substance use disorder in general, and with mental illness. We have seen a lot of the concurrent use. So I think after the gentle messaging and the moving forward, I think, and the support from NRT and the counseling that's very specific, I think it's been very overwhelmingly, it's been a positive experience, and very grateful for the help that we've gotten to move forward in this process. Any questions? We'll be happy to answer those. If not, really want to thank you, Mr. Thomas, for this opportunity, and Amy McGarity from Partners for inviting us today.
Absolutely. Dr. Corey, Rebecca, Bradley, I love the testimonials, and it's powerful to hear how it's working. And we're not done yet with the testimonials. We have from Daymark Recovery Services, Michelle Ivy is giving us a video message, right? And so if Mandy's got that queued up, I'll go ahead and let her play that. And this is the beauty of virtual, right? Even though Michelle Ivy may be somewhere else, she gives us this message. So watch this and see where it goes. And it looks as of right now, give you a little play-by-play here, that technology may not be our friend today. What's your thoughts there, Mandy? Let's troubleshoot this on the fly.
It looks like it's freezing up. I'm going to try to do something else here. Just one sec.
All right. We'll stand by. I've got to say, as a former smoker, I smoked for 29 years and I quit in 1999. I'm very thankful and grateful for that. However, I sure wished I had you people in my life at that time, because that was absolutely on my own, the hardest thing I ever could do. Had many adventures in my life, and that was the most difficult. So I'm super glad that there's consistent messaging, and Dr. Corey and your team, it sounds like that's what you're doing, consistent messaging, so that all of your staff, all of your outreach has that message. And I can appreciate that. I really can. Because becoming tobacco free is going to be different for different folks. Just as Delton talked about, it's very possible that his path was quite different than mine.
Would y'all like me to try? I've pulled up the video. Let me see if it'll work for me, and we'll give it one more shot.
So a little bit about how we went about implementing our tobacco-free policy.
Well, we just had it.
Actually writing your policy and figuring out how you're going to go about doing this and how it's going to apply to everyone. So staff, any residential or 24-hour facility, outpatient facility, that type of thing. Unique challenges tend to be things like psychosocial rehabs, and we've gotten a lot of questions about that. We do not provide a residential service, so we did not encounter that issue. But we did a couple of things to prepare for the tobacco-free. First was the Million Hearts Change Concepts. We selected our Million Hearts change concepts to make tobacco cessation practice and system priority. That was one of the ones that we selected. We also selected creating a supportive environment for cessation. And then throughout that, with the other change ideas, we selected ones from each different category. And so that's an important piece of the implementation, is to look at what the culture of the agency or company is going to be around tobacco cessation. Another thing that we did was we created an FAQ, and this was for our staff, and this was for clinical staff, administrative staff. Everyone got a copy of that in advance. We began this process in, I think, January. It was almost a year before we actually implemented the change. And we took a phased-in approach. We first determined that we would implement a tobacco-free policy for staff first. And then 3 months later, we would implement it for the client population, so the individuals that we served. The FAQ went through the policy, who was affected by the policy, when the policy would go into effect, what types of tobacco use was included. And so vaping, dip, snuff, that type of thing. Does it cover e-cigarettes? That was included. Smokeless tobacco of any kind. All these things were included in our FAQ. Policy enforcement, violation of the policy, how to report a complaint if needed, who has the authority to implement. All these were things we included in this FAQ that went out to staff initially with the policy. The next thing that we did is we undertook a massive training effort. We probably have somewhere around 600 employees with an additional 150 to 200 contractors. Actually, I think it's slightly more than that now. But we worked with our local coalition, Change for Life Coalition, on implementing some training. So for clinical staff, we had at least one clinical person from each location attend a 3-hour training, and then at least one administrative or support staff person attend a 1-hour training about tobacco cessation. So these were offered, I think we had about 10 to 12 different offerings, different times a day, different dates. And we had a large number of staff that were trained. We also had more than one from each location, but the minimum was at least one. And that included our finance office, our IT office, human resources. Everyone had to at least send one person. And the goal was for that at least one person to then go back to the team and share what it is that they had learned. And I think that was probably the biggest thing that we did that made a huge difference in implementing our policy. It's really easy to just say, yep, we got to do this, give it lip service and move on. The training made a huge difference. It is a huge time investment for staff. It was a huge investment from a productivity standpoint. And in the end, I think it paid a lot of dividends for us to be able to go through that training process. It made a lot of difference in, I think, staff's acceptance and understanding why we did this. And it wasn't just a case of, well, the state said you have to, or the payer said you have to. It really put some teeth behind the reasoning to encourage our staff to go tobacco-free, and also the people we serve, helping them go tobacco-free. We did have, I think, about 4 staff that went through the certification training with Duke. That was something that was completed. We had a couple of clinicians and also medical providers that went through that training. And that was very important in helping us champion this change within the agency. So those were the main things that we did. Barriers that we've seen. Obviously, you're going to have some people that they just don't want to do it. They don't want to give up tobacco, and that's their right as a human being. But then how do you help them get on board? Obviously, removing any type of smoking area and putting something else there, especially with PSRs. This was very important, or any type of program where people are there for a longer period of time. Being able to put something there to help a person engage in a different behavior. And so using those clinical behavioral skills that all of us know and are very familiar with. So those are some of the things that we did. And then for folks who particularly may have had some resistance, making it part of the treatment planning. What can they do differently to help them? Example from a PSR, a person that they were not on board. They did not want to comply with the policy. So we made it part of the treatment planning. So what are some things that you can do instead of using tobacco at the time you ordinarily would take, quote, a smoke break? How can you use walking? Are there other activities you can engage in? And so those are some things we did on the treatment level to help make this work a little better. There is no perfect way to implement. There are always going to be barriers. And I think through training and perseverance, you really can make this go more smoothly and get more people on board. So that's in a nutshell what we did. We at this point have completely implemented our tobacco-free policy. We have completed our Million Hearts Change concepts that we selected. So that is in place right now. We will continue to provide tobacco cessation information to the individuals that we serve. We will continue to encourage staff to engage in tobacco cessation. One other thing that we did with staff is we contacted our insurance carrier and received information on how our health insurance carrier could assist people who wanted to quit using tobacco. So that was another piece of it for staff and helping them achieve their goals, those that desire to stop using tobacco. Did you have any questions, Delton?
No, not at all. That was incredibly comprehensive. Thank you very much.
And indeed it was. Thanks to Delton and Michelle Ivy for putting that together for us. Glad we could finally bring it to you. Great testimonials. So you see it put into action. I love it. Before I bring on Joyce Swetlick, I just want to mention her as she's preparing. I want to mention and encourage you to look at the chat box. So if you haven't already, please open up that chat box. There is a host of links in there for resources. There is no shortage of resources. So even while you're in here, click those, just leave the web pages open. It's all good. Never enough. So with that, Joyce Swetlick, are you ready to bring up your information?
I certainly am.
All
And
right,
here we
fantastic.
share.
There we go. Hey, it's on.
Well, thank you, Ted. You sound just like a radio announcer. I love it. I love it. And congratulations
Thank you.
on being tobacco free.
Hey, one of the best decisions I think I've ever made, besides marrying a North Carolina girl.
There you go. Well, I am so glad to speak with all of you about the North Carolina resource available to you called the Quitline NC. As Director of Tobacco Cessation, I've worked in the area of cessation, prevention, and control since 1991 and have spent more than 18 years running tobacco use dependence Quitlines. Okay, let's see if I can get this going. So the Quitline NC is an evidence-based telephone tobacco treatment service with 24-hour coachings through the telephone, texting, or web, or a combination of the three by highly trained professional quit coaches. They also provide combination nicotine patches plus gum or lozenge mailed directly to the eligible participant's home. It's available free to all North Carolina residents. It's accessible 24 hours a day, 7 days a week. They have coaches that speak English, Spanish, and they have a translation service for over 270 other languages. So, although the Quitline may not be as effective as face-to-face counseling through individual or group interventions, which can be as intensive or, as you can make them, Quitlines provide a variety of modality of services that are meant to be population-based and hence have a greater impact on treatment. Impact equals reach times efficacy. For example, if you have a strong intervention and have a quit rate of 50%, and you see 1,000 people per year, your impact is going to be 500 people quitting tobacco use. But if your Quitline has a quit rate of only 30% and you reach 10,000 people, then your impact is 3,000 people quitting. Quit rates by Quitlines have increased over the years due to engagement, nicotine replacement therapy, tailored programs, and making them more equitable. So moving the needle may mean there may be a natural trade-off where we implement a program with a little lower efficacy in order to reach more people, having a greater population-based impact. So with the phone counseling, it will take about 10 to 15 minutes to register with a registration specialist. And then the participants will be transferred to a quit coach. So ensure that your participant has 30 to 45 minutes for that first call. In the regular multiple call program, participants in the Quitline set a quit date and arrange up to 3 follow-up calls from the quit coach. The participant who has completed all the calls can always call the Quitline back if they relapse or if they're afraid they may relapse again. Over the years, our evaluation have consistently shown a dose response. Those who complete more calls have a higher quit rate. So the text to quit is also available as an adjunct to the calls or the web or both. The text to quit is an evidence-based series of text messages personalized to a participant's quitting plan. It integrates with the program, allowing participants to access their data and track their progress, whether they are talking to a quit coach or working with a web coach. So the web coach, let me get to there we go. The web coach is designed to support and assist tobacco users throughout the entire quitting process, from creating a quit plan to learning the strategies needed to stay quit for life. Participants will also have access to an online community and chat with the web coach. So individuals can self-enroll in the quit line in one of three ways. They can either call the 1-800-QUIT-NOW, which is 1-800-784-8669, or they can go online at www.quitlinenc.com and register online if they don't want to use up their minutes, or they can text READY to 200-400. So when an individual goes to quitlinenc.com, they will come to this page and they can choose to register online rather than answer all the intake questions on their phone. So please note that the quitlinenc.com will become quitlinenc.gov in the future, and it's going to you won't be able to get to .com after December. So it will be quitlinenc.gov. So once a participant begins to register online, they can choose to work with a quit coach through proactive telephone calls or work their program online and chat with a web coach. You will notice that texting and web on this slide is for everyone. Because we get a limited amount of funding from the state, we try to use the money the best way we can and buy more services to those in greatest need, such as those who do not have insurance or resources, those on public insurance like Medicare, Medicaid, pregnant women, people who live with one or more mental health condition, young people under the age of 18, American Indians, and active duty military. We also have partnerships with the insurance plans, such as Blue Cross Blue Shield of North Carolina, all the Medicaid managed care standard plans, and large businesses like the furniture companies of Rock House Farms, Family of Brands, and countywide programs. As well as in the future, we will have the tailored plans. Without these partnerships, we would not be able to offer the tailored programs or the more intensive services to the uninsured. Today, when a person who is insured by Medicaid calls, they will receive a standing order with their 2-week starter pack of combination NRT. They will take this to their nearest pharmacy and receive 12 more weeks of combination NRT. In 2023, we will be able to send the 12 weeks of combination NRT directly from the Quitline NC pharmacy, taking any burden off the Medicaid recipient. The longest specialized program Quitline NC has is the pregnancy program. This program is not only for pregnant women, but those who plan to become pregnant within the next 3 months, those who have given birth in the past year, as well as those who are pregnant. The Quit Coach will provide tobacco dependence treatment for the woman separate from the expectant mother. It also emphasized the importance of staying quit after delivery of her child. Because we found a health inequity from looking at our data among those with one or more behavioral health disorder compared to those without, we enacted our behavioral health program which extends the number of calls and combination NRT with specially trained quit coaches and communications with the behavioral health care provider of the participant. As you can see here, these are many of the health conditions that we ask about. If someone states that they have bipolar or schizophrenia, they will automatically be offered this program. However, if someone says they have depression or general anxiety or some of the others, then they will be asked if they think that their mental health condition will interfere with their ability to quit. And if they say yes, then they are offered the program. For our Native American participants, we now offer a separate phone line, which will connect them to a Native American Quit coach, or a coach who has been specially trained to work with Native Americans. The logo that you see on this slide was a collaboration between the graphics artists at our department and the members of the Native American tribes in North Carolina. And in the future, we plan to hire some Native American coaches from North Carolina to be part of the coaches within the Quit line. With African American Black participants, Pathways to Freedom videos are integrated into the participants' counseling sessions. These videos provide specific content for the African American Black participant regarding cessation techniques, health problems, targeted advertising by the industry, and menthol products. This specific protocol was studied in North Carolina and was proven to increase the engagement and the quit rates of the participants. Because active duty military would be insured, they initially received only one call from Quitline NC. We now have instituted that they could receive 4 calls and 8 weeks of combination nicotine patches plus gum or lozenge. If someone calls with limited English proficiency or whose primary language is Chinese, Korean, or Vietnamese, we will direct transfer them to the Asian Smoker Quit line, where they can speak to an individual in their native language. They will receive 5 calls plus 2 weeks of NRT. Veterans with insurance will be transferred to the Veterans Quit line to receive more robust services than we offer. And the Quit line also has a Facebook page to encourage tobacco users to quit and inform them of program opportunities. You can follow us by typing in @QuitlineNC to get to our page. So beginning March 2023, Quitline participant experience will be a little different. Participants will receive 5 coaching sessions with 3 individual sessions with a coach, either through the phone, through live SMS texting, or online through a chat. A group video will be offered for the 2nd and 5th session, as shown on this chart. Participants will still be able to enroll into the text messaging support and, of course, the integrated web program. There will be integrated digital support through the central dashboard. And as well as the participants will be able to order and track their NRT to their home. So now the NRT takes between 7 to 10 days to reach a participant's home. When we move over to this new platform, it will take between 3 to 5 days for the participants to receive their NRT. So they'll receive it much quicker. They'll be able to track it, and it'd be less likely for their NRT to be lost. So for the providers, we are now providing you with more opportunities to refer to the Quit line rather than the antiquated paper fax. You can send an electronic fax through your EHR directly to Quitline NC, but you will need to work with your IT and possibly your Quitline or your EHR vendor to set this up, which is not too difficult, but can take a little time. The ultimate alternative would be to provide a bi-directional referral loop to the Quit line through your EHR, in which your providers would just press a button to refer to the Quit line like any other referral, and the outcomes reports will be sent directly back into the patient's files. but this can be expensive and it's also very time consuming, and it would increase your referrals to the Quitline in the long run. But there's a setup fee with the Quitline NC. So we now have created an alternative between option 1 and option 2, where you can e-refer through a referral portal that is free to you without any time consuming or expensive setup. So to refer to Quitline NC, we strongly encourage you to become a Quitline NC referral site. As a Quitline NC referral site, you will be added to the web portal. You'll receive outcomes reports through secured email, so you can put it in your patient's records. And this outcomes report will provide you whether or not the patient was reached, if they enrolled in services, if they plan to quit, and if they engaged and how much they engaged with our services. You'll receive monthly aggregate reports of your sites, patients referred to the Quitline. You'll receive updates on new services, promotions, or changes regarding Quitline NC. And then you'll receive ongoing technical assistance and training on the referral process. So to become a Quitline referral site, go to the quitlinenc.com or .gov and download the registration form. You can get to the portal by clicking this link. And if you forget how to use the portal, then you can download the guide on how to use the Quitline. And I'm going to show you what's in the guide and how to use the portal. So once your agency is registered as a Quitline NC referral site, you will be added to this portal. This is the first thing you see on the right when you go to the portal. You first need to find your name of your agency. And once you find your entity's name, you'll click on it and it will change. Okay, let me get back to that. So once you find your name, you'll click on it and it will change to this site. And on this screen, you'll see that to receive the outcome reports of your patients or clients, ensure that the HIPAA box is checked. So if the information has changed from this page, contact Miriam Ali, which was listed on the previous slide, and she will get it changed for you. After you click Next, enter the patient's information and click Submit. So it's easy peasy, 3 clicks and submit. So you can just think of that. So upon submission, the Quitline will reach out to the tobacco user and offer enrollment within 48 hours. As with the fax referrals, the HIPAA covered entities will receive the outcomes report detailing the participant's enrollment status. This will be provided through a secured email. So if the person making the referral does not include their email address, the report will be sent to the fax number on file. So in 2020, we found the percentage of participants using Quitline NC were at or above the percentage of those who smoked in the populations that experienced tobacco disparities. As you can see from this chart, more than half of our Quitline callers are heavy smokers with only a high school or less education that lives with one or more mental health condition, which also includes substance use disorders. In North Carolina, e-cigarettes and vaping products are defined as tobacco use products. So we look at this and the quit rate is at 32%. We also see that most who register make at least one quit attempt and 3/4 at least reduce the number of cigarettes or other tobacco products used. The odds of quitting were significantly increased with increased number of coaching calls completed, and also higher among people who do not live or work in a smoking environment. So compared to people who live or work in a smoking environment. That's why it's very important to have individuals treated at smoke-free work sites. Our satisfaction rate has been consistent. We have been seeing those very satisfied, significant, consistently rising each year. In 2021, 3/4 said that they would use a quitline again if they did not quit or if they start using again. And this slide shows the disparity among quitting before and after the behavioral health program. And we are seeing a reduction within that rate once we started the program, as you see here. Over the years, we found the return on investment, especially since providing NRT, is for every $1 invested, there's a $3 to $4 saving in healthcare cost. And just real quickly, I want to talk a little bit about, in 1 minute or less, that we now have an epidemic among our youth. And 2 out of 3 young people who currently use e-cigarettes are seriously thinking about quitting, and we can't leave them out. So we started a program, we have a new program called Live Vape Free, where the students can get to it by texting Vape Free NC to 873-373. They enroll in a multimedia experience that includes videos, quizzes, self-assessment, flip cards, audios, and podcasts. And they have access to a coach at any time by texting the word coach, and they can text live with a coach. And as part of this, there's an online course for concerned adults at www.livevapefreenc.com. And parents are given a wide variety of media-rich resources they can use as conversation starters to help their kids on track, staying vape-free or quitting, and including online learning and chat support. So with that, I will send it on to the next person.
Thank you so much, Joyce. Again, I hope if you're here, you're listening to the messaging, right? And we're not done yet. So we still have a couple of panelists to bring on. Stephanie Gans is coming up next, and she is the Tobacco Prevention and Control Branch specialist for North Carolina Department of Health and Human Services. So Steph, I see your video here. Are you able to present?
Yeah, absolutely. Just
there you go.
Go ahead and share my screen. Hi, everybody.
All right, you got it.
And in addition to working with Joyce on helping, physical and behavioral health settings integrate tobacco use treatment, I'm also the lead on our statewide effort to eliminate tobacco-related health disparities among people with behavioral health conditions. And so I just want to start this off by saying that what all of you do really, really matters. And so we're going to take a few minutes to talk about incorporating evidence-based treatment into your practice. One thing I'd love to highlight is that, during the pandemic, we did see, and obviously it's ongoing, but we did see this decrease in quit attempts and people calling the quit line. People went through a really stressful time, and there were less, there seemed to be less quit attempts, and people also had less access to the healthcare providers because the health system was so overwhelmed, to the healthcare providers that normally would have maybe spent time with them doing the screening and brief interventions that I'm going to talk about. So it really, really matters what we do in terms of whether or not our patients try to quit. One bright spot for North Carolina in this whole process was that due to the work that is being done by a lot of the people on this phone call, we did see that one group did have an increase of people calling the quit line for the most recent data that we have during the pandemic, that that we actually had an increase in the number and percentage of the folks calling the quit line who had a co-occurring substance use disorder. And that really goes back to the work that people like the folks on this call have done in terms of referring people to the quit line. So just because there are national trends and there are things that are going on, you as a provider and the things that you do impact whether or not your patients will make a quit attempt, actually connect with the quit line. And so since we had that sustained focus with those organizations, we did see an increase, even though overall, just in the national environment, things were going down. So in North Carolina in 2021, our behavioral risk factor surveillance system survey estimates that in the general population, 57% of adults who use tobacco received advice from a health professional to quit. Again, this was actually a decrease from the previous years, I think, again, because of everything that I just said. 59% never discussed any form of treatment with a healthcare provider. And only 27% discussed evidence-based treatment, both medications and counseling. And so, our goal is to see, if what we do matters, how can we increase that and at least be having those conversations? Quitting is hard. Less than 5% of people who go cold turkey quit in the long term. When I say cold turkey, we're defining that as we're defining that as not using anything to really help you quit. So no counseling, no medications. I think someone mentioned earlier how hard it is to quit. And so the point of this is to make it more likely that on their next attempt, the person is actually able to be successful so that they never have to try quitting smoking again. That being said, it does take someone on average 5 to 7 attempts. It will take people multiple attempts a lot of times. I was just talking to someone who had quit smoking successfully, who was telling me how, she had tried so many times, and that the first time you try anything, you're not going to be good at it. And so it does take some level of persistence and trying over time. But there are things that we can do as providers to make it more likely. So most of the people who smoke do try to quit every year, but most don't utilize evidence-based treatments that can double or triple their chances of success. And so what are those evidence-based treatments? Well, we have it summarized as in the North Carolina tobacco treatment standard of care. It's a combination of medications and counseling. So tobacco use treatment is medication-assisted treatment. That combo of the counseling with the medications is really what is going to double the chances of success for your clients. Even then within that, we know that from evidence that there are 2 types of medications that give our clients a little bit even better chances of success, increase their odds of becoming tobacco free. So those 2 types of medication regimens, one is 12 weeks of varenicline, which is also known as Chantix. And I recognize that due to the recall, that has been difficult for folks to get their hands on. But there are generic versions of varenicline that are available and are covered by NC Medicaid, but it's just a question of making sure that the pharmacy actually has it. And we're glad to help you work through those issues. Or 12 weeks of combination therapy. So that means the patches plus the gum, the nicotine patches plus the gum, or the nicotine patches plus the nicotine lozenge. And that's what we would call combination therapy. A lot of clients have not actually tried those medications in combination and maybe have not had adequate treatment then for their nicotine withdrawal. So in a 100% tobacco-free environment, just like Joyce was saying, great evidence for why a tobacco-free environment helps people quit. People with a co-occurring behavioral health condition might require longer and more intensive treatment. And for pregnant people, counseling is first line because the medications can have a potential negative impact on the fetus. If someone is really having a hard time quitting while pregnant, continuing to use tobacco products is much more dangerous than, for example, using the gum. So as Joyce, I think, probably mentioned, you can do like a medical override with the quit line and get the gum, and then the provider can, obviously, the actual medical provider for that person can have a conversation about the risks and benefits and make that decision. So there's a harm reduction element as well. But in general, for pregnant people, counseling is first line. Tobacco use disorders in the DSM-5, it's, got this similar, diagnostic criteria to every other substance use disorder that's in the DSM-5. Tolerance develops. A lot of people experience that tolerance as just not getting the enjoyment that they feel the need to smoke, or they feel the cravings, but they don't get the enjoyment that they previously got out of smoking. A lot of people feel like they're doing it if they've been doing it for a long time out of habit, or only the first cigarette of the day is, they enjoy. There's two parts to tobacco dependence. There's the physiological addiction to nicotine, and there's the behavioral component. And the behavioral component also goes down even to how our brain is wired up. And we need some time for our brain to kind of rewire with the different behaviors that we're going to do instead of smoking, in addition to just, thinking through how are we going to live our life? How are we going to cope with these emotional situations and the things that trigger us to smoke? And so that's why, again, we need that combination of treating both the physiological elements and the behavioral elements to address tobacco use. Our U.S. Public Health Service guidelines, we know that tobacco dependence is a chronic condition. Effective treatments exist. All people that use tobacco should be offered treatment. And so we're just still trying to figure out how can we reach that goal as much as possible in North Carolina, that everybody that uses tobacco is at least offered treatment, right? So how do we do that? We have the 5 A's. And so the 5 A's, stands for ask about tobacco use, advise folks to quit, assess folks' interest in evidence-based treatment, see where we can meet them where they are, is a good way to think about that assessment. Assist with evidence-based treatment, and then arranging for follow-up care. So I'll talk a little bit more about what each of those are, but it basically maps onto the brief intervention that also exists for alcohol and other drugs. For those of you that are on this call that have experience with maybe being in a healthcare setting or doing, again, brief interventions, SBIRT, so screening, brief intervention, referral to treatment, the 5 A's is the same as that, just different for tobacco. We know that the 5 A's can also increase quit attempts in teens. We still need a lot more research on what is the standard of care for teens. So the standard of care that I gave is the one for adults, but we do know that the 5 A's can increase quit attempts in teens, and the American Academy of Pediatrics has great youth cessation resources, including information about how to make an informed decision about using medications with teens that are vaping. So the first step of our SBIRT is screening, right? So that's, or 5 A's, ask, right? So we're going to ask everyone. How do we create a system to ask everyone? One thing I want to highlight while we're talking about the ask is that, so NC TOPS has a really good, it didn't used to, but now it has really good tobacco screening question for adolescents and for adults. So if you are going to be doing NC TOPS with your clients and collecting data that way, then you can utilize that information, and that will even give you more information than just a screening, because it gives you what products they're using and that type of info. So that's a good place to start also in terms of starting to do evaluation. You would probably want to also add to that, not just, are you using tobacco, what products are you using, how frequently are you using, but understanding their history of quitting, understanding what medications they may have tried, that kind of stuff. But it's a great place to start. But even just the basic screening, do you use any kind of tobacco such as cigarettes? What about electronic smoking devices like e-cigarettes or vape pens? It's very important to kind of single those things out. It can be helpful to say brand names sometimes. When we changed the tobacco screening questions in NC TOPS to very explicitly call out e-cigarettes, we didn't see a huge change in how many adults screen positive for tobacco use, because a lot of them are dual users pretty much. So we didn't really see a huge change there, but we did see a big change, unfortunately an increase, but it means our data is more accurate, in how many adolescents screened positive for tobacco use, right? So because they were vaping and maybe that was the only product that they were using. And so it is very important to call those things out, because think about how many adolescents we potentially are missing out on offering treatment to because we didn't ask the question correctly. Another good way to kind of have the conversation is to have let some of these questions guide your conversations, because these questions are designed at getting at our reasons to stay the same and our reasons to change. And people are a lot more open to talking about their reasons to make a change if we also acknowledge what scares you about quitting. What role is this playing in your life, right? I mean, what role is kind of what's good about smoking or vaping or tobacco use. And so this can be a useful thing. If you can have like a couple minutes to ask one of these questions, and get a sense, you might be able to give a much more personalized advice to the person, and person-centered advice, because you're making it relevant to them instead of relevant to whatever you care about as the provider. If someone's not ready to quit, another good sort of like counseling strategy is to ask, do you ever plan to quit? And to ask that in a way that is, non-judgmental, like, do you ever see yourself, trying to quit, or is this something that you think you're going to continue to do? And a lot of people will say, yes, it's just not a good time right now, yada yada yada. And so we can always ask what might be some of the benefits of quitting now instead of in the future. You will get then even a smaller subset of people who say, no, I never plan to quit. But again, like, that's good information for us to have, and we can still give a good personalized advice based on their goals and always come back to it. What would have to change for you to decide to quit sooner? Maybe that's a good note for us to then know, okay, when is a good time to come back around on this? Our advice should be clear, strong, and personalized. So here's a few different examples. You really value your recovery. One of the best things you can do to be successful is quitting all forms of tobacco. And so that's a message that a lot of our clients potentially have not heard. I think Delton gave good examples of the kinds of messages that have been out there historically for people with behavioral health conditions. And so sometimes I think in behavioral health settings, we are very adept with motivational interviewing. So we might be able to kind of, have that conversation and have the person come up with their goal. And maybe we never give like a strong advice the way that we would expect, a doctor to, in terms of what they're advising, what the treatment strategy is. But I would say it is important to try to provide this evidence-based information, because a lot of folks have received inaccurate information potentially from behavioral health professionals or just at an AA meeting or whatever in the past about the effect of quitting smoking on our recovery or on mental health or whatever it is. So the next day is assess, meeting the client where they are. We want to ask about past quit attempts is a great thing to ask about. Again, that can help to get at what is kind of the barrier for this person trying to quit at this time, using that motivational interviewing to explore ambivalence, asking open-ended questions, reflecting any change talk we hear. So anything that is that movement toward our reasons to make a change, and identifying if the confidence or importance is low, right? So a conversation is going to be pretty different with someone who the importance is low, where they're saying, I can quit anytime I want to, just don't want to. That's a really different conversation from, I've tried to quit so many times, I just don't think I can do it, right? And both of those things can kind of be barriers. And so how can we have a conversation? If the importance is low, then we want to focus on, okay, well, what is important to this person? And does tobacco conflict in any way with those things that are important? And we may be able to provide some information to help to raise that importance, or we may be able to slowly over time call their attention so that they observe that conflict as well, developing that the discrepancy. And then if the confidence is low, again, that's a different conversation in which we are trying to understand what is the thought process there, and what are some of the things that might make that person feel a little bit more confident. And we might be able to troubleshoot a little bit of what are the things that have happened in the past. We might need to use some of our CBT skills there. We also want to be trauma informed. Obviously, we want to be trauma informed in all parts of behavioral health and healthcare, and that the same is true with tobacco use treatment. And I think the thing to emphasize here in the short time we have is that punitive responses to, it says teen e-cig use, but really we're talking about implementing these tobacco-free settings, having any sort of punitive response to tobacco use rather than treating it as a therapeutic opportunity, an opportunity to engage with the person and figure out both what can we do better as providers so that this person is set up to be successful in terms of being tobacco free while they're on campus, and that they're successful overall in either their goal of quitting or whatever it is, that's not, trauma informed. We want to treat it as a therapeutic opportunity to engage with folks. Our evidence-based counseling strategies for tobacco use are cognitive behavioral therapy, mindfulness training, psychoeducation about tobacco use. Ooh, and I recognize we have very little time left, and its impacts. I do want to, all right, let me see. We have the last two A's, and then I want to say something about billing, but I want to emphasize too, since I don't have a lot of time to say anything about billing, that you have a copy of the slides and that there's a great resource that is like a comprehensive billing guide that I'm going to give to you all. And I hope someone will put the link to that in the chat as well. So the last A is assist. So we want to prescribe or recommend and advocate for evidence-based medication, and hopefully set some goals. So again, that's part of the assist process. Maybe we're going to set a quit date, or maybe we're going to just set a date where we're going to start our medication. And we want to make a plan about what's worked in the past and what hasn't, and identify those triggers and plan for ways to cope. So that's kind of part of our brief intervention as well. And I gave some examples of tobacco use treatment goals, but I want to make sure that we have time to talk about the billing. I want to emphasize one thing about medication too, which is that smoking actually can decrease the effectiveness of some medications. So when we're working with people with behavioral health conditions, we want to make sure that we're advising the psychiatrist or the prescriber that someone is going to attempt to quit, because they may actually need less medication to benefit. So that's our standard of care. I gave you all resources in terms of nicotine matching. Just again, for your reference after this presentation, this is a great reference for patients to learn about how to use nicotine replacement therapy. The last A is arranging for follow-up. So making an appointment to follow up by phone on progress towards patient goals. And again, so maybe this is the arrangement for follow-up is that referral to Quitline NC. So now we've gotten someone excited about quitting, or at least trying to, and we can do that proactive referral that Joyce was describing using the web referral platform. We want to look at integrating tobacco use treatment as something we're doing on a systems level. So we don't want it to just be, okay, the providers that came to the provider kickoff, that one person is going to do, better doing brief interventions for tobacco use treatment. We want to think about overall across the health system, how can we integrate this at the very least brief interventions for our patients. And then if you can go beyond that and you have the ability to provide more in-depth counseling or group or whatever it is, that's great. But at the very least, I think no matter in what setting, you can at least do a brief intervention for your patients that's screen positive. You have a link to the American Lung Association's tobacco use treatment assessment tool to see kind of where you could potentially integrate this stuff in. And Michelle Ivey mentioned the Million Hearts Tobacco Cessation Change Package. It has the comprehensive list of all the health system changes you could make to better integrate tobacco use treatment. So the last thing I want to say is about billing. So brief interventions are billable for MDs, PAs, and NPs. Also, evaluation and management codes are billable for those providers. You would need to make sure that the codes for brief interventions or those medical visits that you might have were included in your contracts with partners as a service that you are providing. The problem, and there is a list of all of the diagnosis codes that are billable for tobacco use treatment. So when I say that I gave you all that list, that there are references in the slides that we don't necessarily have time to go over. These are the two codes for the brief intervention. And NC Medicaid does cover that. It's just the problem is that if you're a behavioral health professional, you can't do like incident to billing to the physician or nurse practitioner or whatever to provide this directly. So it's really only the physicians, if you have a physician or physician assistant or nurse practitioner, that can bill. But again, if you're doing this work, you should get compensated for it and make sure that that's part of your contract. What I would say is that if you're a behavioral health provider, and I have the incident to guidelines for Medicare and a list of what to include in your documentation, and an example of the types of note templates or documentation things you might want to use. So we have like really comprehensive information. The best, most comprehensive billing guide is the ALA's Tobacco Cessation Billing Guide for Behavioral Health, of which the link is on this slide. I would say, so for behavioral health professionals, what you would do is you would bill those services can be integrated into the services you're already providing. And so if you spend a little additional time on tobacco use treatment as part of this person's, overall treatment for their substance use disorder or overall treatment for their mental health condition, just document that and document how does that impact the substance use disorder? How does that impact the mental health condition? I think we've already talked about very specifically how it impacts it and why it's related and why this is part of the patient's goals. And so you can do that, and you would be billing for that under the service you're already providing, for, alcohol use disorder overall as the primary diagnosis, but there's not a way to do it for just tobacco use treatment at this time. But certainly it impacts that person's alcohol use disorder. And so you can document that and just make sure you document the relationship that it has to that person's goals, which I think is pretty clear. So I hope that answers all the questions. I know we're running behind and I went a little over time here.
Hey, Steph, I've just got to say, out of everything that's happened today here, this is robust. It really is. And so, yeah, we're going to move on. Thank you very much, Steph. And David Willard, you're up next. Once Steph will stop sharing there, then you're able to bring yours up.
Ted, I would
Right, there
say
you
this is
go.
the fun stuff that David's going to do. So I hope people will hang with us because this really is
Yeah.
great information.
And I'll agree. I mean, hang around with us. You've been here this long. We still want to wrap this up and give you the best information. So, David, no pressure. You got it?
I hope so.
All right, let it roll.
All right. So yeah, we'll talk a little bit about some of the environmental support. So if you've been following along with the little pathway, this is the one that's all the way at the end there. So after you've done all the hard stuff, so then I guess as it's been billed, we'll start doing some of the fun stuff when it comes to the tobacco control. And here's just a couple of questions to ponder. I'm not going to read them all, but it's mostly about, do your clients know the policy is going to be in place? Do you know that all of your staff or new people know that it's going to be there? Do people understand what tobacco free means, that they're, and all the nuances that come with all those jargony kind of things when you get down into it? So, do you got motivational quotes around, and then of course structuring the physical environment messaging systems to support the tobacco free culture and care. And it's just about that whole person, whole health kind of thing. And then of course the signage, your outdoor signage is your most important, I would say, way to advertise your policy. So you see if these are out in the open, you can see that they have many signs there. And we're going to see a whole bunch of different kinds of signs here throughout this presentation. But so that's your number one, the signage. That's how you let everybody know that this is a tobacco-free campus, and these are the rules. Here's more signage. It's at a Nuvia. Similar signs, of course. And then there's some of these signs that became a little bit more eye appealing, I think, and a little bit more for, a door, letting people know, again, this is a tobacco-free campus. And then, of course, branded with the Change for Life, which, of course, is the Region 4. More signs, of course. And then banners. So this is something that Carlene did down in Region 4. So they were able to purchase these nice banners and put them throughout their facilities as well. That covered 5 counties. So that's just another good way to let people know. This is kind of a good thing that you can maybe do even early on, just to let people know that this is going to be tobacco free. So putting these things out in lobbies where you can start letting your clients know, yeah, we're going to be going tobacco free, start prepping them. You guys know all this kind of stuff. So keep moving. And then more of the banners throughout the workplace. And then these are just some more examples of the banners. And then if you notice, these banners also can be marked with the logo from your organization to put on there to be able to, make it your own, if you will. So those are there. There's more banners, posters. We can do either one. More of the same. And these are little, like the cards that you fold down and put on tables, or business cards, that kind of deal too. You can have some things like that, just more ways of getting that. So prepping the environment. So this is where it gets even a little more fun. Signs are boring, but they're your most important. So preparing your environment, so transforming smoking areas maybe into wellness areas. So we look at a little bit about, ways that others have kind of tackled that issue, and then building activities for healthy socialization. So that's just making these places that are a little bit more like kind of water coolery, but maybe outside. And then some more of the preparing of the environment. Other things you can do as simple as tossing a football. I like throwing football. I love the Bills, so go Bills for all my Bills fans out there. And then other activities you could do, a calming bench with soothing herbs or plants around. So you can plant a little herb garden too, which guards will get into a little bit too. And then, so this was Hope Haven. They transformed their smoking area into a fitness area. So you can see they're out there working on it. And then they had those outdoor workout equipments, which you can sometimes see on greenways and stuff. So they brought that into their smoking area and made it this instead of a smoking area. And then Nuvia with their walking paths and gardens that they had created. Just a nice little outdoor environment that's welcoming. And here's some, of course, garden spaces, community gardens at wherever you're located are always kind of fun. They're a little bit, they take some work to go. Of course, everybody knows growing plants, they take some work to get them going. But if everybody gets in and does it, then it works out pretty good. Partner with a local therapy dog network. So everybody, I don't want to say everybody, a lot of people like dogs out there. So that's always fun to have dogs around if you can find an opportunity like that. Not everyone will be able to do something like that, but that's just another, idea. And of course, providing the opportunities for your people to express their artistic side and their creative side. So having opportunities to draw, color, do a maze or any of those other kind of fun books that we all used to do a long time ago. And then here's some more just rat cards. So this is, what you would kind of put out in your lobby for your clients or whoever's coming through to look at. So it's got all the information there, about why it's important. And the same, more so here, some of the tobacco history and mental health on the back of this card. Client, family, audience. So you see that they're all addressed to different audiences too, which is nice. More about the addiction of tobacco, nicotine. Motivational cards, just another something that you can have around where people write a little note on the back. More of the same. And then there's just a little quote from a Change for Life coalition member. And so some of the importance of having NRT on site as an environmental health, there's always a question that comes up, and it's always going to be, do you have NRT? And, a lot of places really don't have it. And so it's really nice to have it on hand to be able to give out right on demand, if you will. So there's no waiting, so that they can kind of, get going on their journey. Here's just some steps for requesting free NRT. We'll just let that be in the slideshow. And then here's some more of the Quitline NC brochures. They were in other things, so we'll just kind of keep going. More of just brochures out, how you can set up your lobby. Of course, that's all up to you. And then here's more quit books for tobacco treatment. There's more resources that can be out in your lobbies. And then this is just kind of going over the environmental supports for the tobacco-free campus. So that's all kind of what we covered today. And of course, celebrate. Everybody's got to celebrate. And then, so what other ideas and all the questions and whatnot. So I'll just end the presentation there, somewhat get us back a little bit more on closer to time.
David, thank you for taking us through the environmental piece. It just shows us examples as to, what we can do. So I appreciate that. David, Steph, Joyce, Let me see, Carlene, Kim, thank you. I'm going to turn it over to a good friend of mine, Delton. I want to hear from you to wrap us up today. So it's on to you.
Hey, everybody. So, we can see, having gone through all this and having heard from everybody today, that, this isn't just a Medicaid mandated thing, that, there really is a tremendous amount of value in it. You've heard from several people that have shared firsthand, myself included, the value of not smoking, especially in relationship to our recovery, our mental health. But also, it's just moving forward, with health outcomes for all people in the community. It's really important. So anyways, thank you all for being here today. We really, really appreciate you. Just wanted to open the floor. If anybody has any questions, we'll be happy to answer those for you.
And I do want to take just a moment as well to remind you that we are rolling out our tobacco-free mini page under our provider knowledge base, and all of the references that you've seen flying across the screen today, our team has been really great about putting links to resources. We're going to be including all of those links for you on the website. So you can look for those if you happen to miss them today or whatnot. And you can always reach out to us. We've got some contact information. Let's see if I can advance this. Delton and myself have our email address. We can help connect you. We also have Carlene, David, and Stephanie Gans up here in case you have specific questions for them. They have been more than willing to make themselves available to help you in your transition. Again, we recorded this presentation today. We're going to make it available to you, and we're going to send our participants the slides today, so you will have that to look forward to. But yes, now's the time for questions. If anyone does have some specific questions, I think I saw one in the chat.
It was from me, Melissa Hatton.
Okay, Melissa, go right ahead.
I've had several providers that were unable to attend this today, and they just really wanted to know if there would be a way for them to access this video later. And I think it would be great because this was a lot of useful information.
Absolutely.
And if you want a deeper dive into this, there is an upcoming free 3-hour training offered by Anuvia with CEUs. And we put that information in the chat. It is on October the 27th.
And did anyone answer Amber's question? I think Amber asked a really good question in the chat.
I think Stephanie, that was directed to Stephanie.
Sure, absolutely. So Amber said, what do you do with clients who refuse referral to Quitline and refuse treatment while they're in the program, i.e. whose plan is to continue smoking when they return home? And I would say, first of all, you know what, that's okay. I think that's one of the top questions we get sometimes, and sometimes a way that the tobacco-free policy requirement has been interpreted. One thing that will cause providers anxiety is being like, oh no, this means all my clients need to set a goal of quitting smoking. And it's just not true at all that that's the case. Just like none of your clients have to set a goal of quitting whatever other, substance or whatever. We still want to provide them the treatment and resources that we're able to provide them, meeting them where they are, and that are appropriate for where they are in their journey. And so sometimes there's a situation of being able to meet with the client and say, if you're here, this example, the question that was asked is if they plan to continue smoking when they return home. So I assume that this is an inpatient or residential type situation where you might have a 100% tobacco-free campus. And so, you know, our state operated healthcare facilities that some of which, you know, a lot of which are inpatient, and then we do have some residential services that are provided, also have that 100% tobacco-free policy. And so then the conversation really becomes about how can we make sure that you are comfortable while you're here? And we have plenty of patients who, you know, go to the hospital and maybe they even had a heart attack, and their plan is to continue smoking when they return home. But that doesn't mean that smoking is a part of the environment and that we don't offer them treatment. We do offer them treatment. And so we can be just as and we should be just as person-centered about this as we would about any other thing. And so I think the tobacco-free policy piece of it is that part of being person-centered in that treatment environment is that for the clients that are interested in quitting, it's really unfair to ask them to receive treatment in an environment where they are being exposed to those triggers to use. And so now this kind of changes the environment to be in line with meeting those goals while not stopping anybody necessarily for when they go home, if that's their plan to continue to smoke. A lot of folks who are able to at least engage in evidence-based medications and counseling, even if they don't set a goal of quitting, if they're willing to engage in that, and you can at least have a little bit of that happen. We know from research that some of those folks will actually go on to then setting a goal of quitting. So the actual motivation that someone has to quit, it is important. It's an important factor, but really everybody should be offered tobacco use treatment, whether or not they're willing to espouse a goal of quitting. And the real question is, what are they willing to engage with? And, you know, while we might not be able to allow tobacco use on campus, that person might be willing to at least engage with, well, I'm really super uncomfortable. I would love the nicotine patch to help me because that's helped me in the past. Or they might say, whatever, I'm just going to, you know, deal with the withdrawals and, you know, kind of be, well, but as long as they're, you know, adhering to the policy, then that's fine. So I hope that that answers it. I think there could be a deeper conversation about, again, people that don't want to quit and, you know, motivational interviewing and further conversation that I did not have time to address in the 20 minutes. I do trainings for folks on, you know, improving your sort of engagement skills with clients on quitting. Okay, that was a long answer. That's a really important question.
Thank you, Steph. Yeah. And I want to keep going back to when our website comes out. Steph has already given us some on-demand treatments that you can access anytime you want. And this will be one of those trainings that you'll be able to access. So we will continue to update. So I have a question for you all. Did we whet your appetite today? I know we threw a lot of information at you, but hopefully, does everybody have a feel for where they need to dive in deeper and learn more in certain areas? Open for comments. Hope this was helpful for you today.
Amy, I would encourage folks to throw in the chat, like, what's one thing you'll take back from this to your setting or in your clinical practice or whatever. If you would be so kind as to just throw like your one takeaway, I would, you know, that's just good info for us for the future.
Great idea. That'll be some good feedback for us too. And to know how we can help you moving forward. So we're sticking with you on this, and we plan to be a support to you along with this team that is there. So please reach out to us and we'll try to connect you with what you need. But yeah, if you can put some comments in the chat about what you can take back, that would be awesome. But other than that, I really thank you for hanging with us. It's been a couple of hours now, so thank you so much for taking time out of your day. And we've enjoyed being with you today. Any other comments from our panel before we wrap up?
Thank you. Thank you very much for doing this.
Our pleasure. And we we will stick around just long enough for, I see 2 chats. If we could just get a few more, that would be awesome. So other than that, we will hang tough for a minute here with you, and we'll let our panel and anyone who needs to drop off at this time and get on with other things in your day, please feel free to do that now. So
I do see people noting, as per usual, I think the Quitline info, all the resources that are available. And someone mentioned the different cultural representatives. Maybe they're mentioning the different tailored services we have through the Quitline.
mhm.
Oh, that's great.
Yeah,
Yeah, people don't, the best kept secret. People don't realize that.
yeah, I think it is. And as time goes on, as we get towards April 1st, I do want to mention that as a tailored plan, Partners is contracting with Quit for Life. It is a version of the same plan for our tailored plan members. And it is the same service as Quitline NC. That's actually the same coaches and the same staff as manning the Quitline, but there will be a different number for Quit for Life for our tailored plan members, and we will be communicating to our members and to you all about some of these nuances as we move forward. We're not quite there yet, and we want to be really clear about how it works. So look for that coming up. Joyce's presentation about the Quitline services was really helpful today. It makes us see all the possibilities. I think it's a great tool.
Thank you.
Thank you, Lavonda. Yes, it was a lot today. Thanks for hanging with us on
it. It can be a lot. And I think sometimes the reason why it's a lot is because I know that when I got my LCAS or my MSW, very little instructional time, actually none, was spent on tobacco use treatment. Even though it's the most popular, substance use disorder in the US. So we have the skills. Everybody here, I think, has the skills. It's just getting the info to make it towards tobacco. So
that's right.
It's great.
So I love pictures, and the tide is turning here. It's time for change. We're going to do it together. So thank you so much. With that, I think we'll close out for the day. Good being with you.
Thank you. Bye.
Thanks, partners.